is referring patients to a higher level of care. We have a wonderful panel for you today, as you can see. Dr. Kaino Mwemezi from Kilimanjaro Christian Medical Center in Tanzania is here. Dr. Mary Rose Osazua from the National Hospital, Abuja, Nigeria. Dr. Anna Maria Crawford, Stanford University, USA. Dr. Jean-Claude Uwimana, Kibogora District Hospital, Rwanda. Dr. Salim Hassanali, Aga Khan University, Kenya. Dr. Shelley Porter, Stanford University, USA. And Dr. Vanessa Moll from the University of Zurich, Switzerland. Just a few housekeeping guidelines that we're going to walk through very quickly and then get the session started. This is Project Echo Etiquette and Housekeeping. Our programming is based on a foundation of love and respect. Please respond kindly rather than react if you disagree with something. We will be using the chat function for Q&A at the bottom of the screen. So please send all questions through the chat box, and please feel free to introduce yourself. If you're able to and your internet is stable, please turn on your video and position your webcam effectively to show your face if you're alone or to capture the whole group. If you have any IT issues, please send a message through the chat and we'll try to help fix it, or to the email listed below. So you know, this session is being recorded and your attendance is consent to be recorded. And I just want to mention, please be mindful of infection prevention and control. Try to limit the numbers of people joining from one gathering place and practice physical distancing. Very briefly, we have interpretation today in French and in Spanish. So if you look at the bottom right of your screen, you should see an interpretation button. You can choose to mute the English part of the session or to listen to both. Translation will be louder than speaker, but if you choose the French or the Spanish button, as you see on the left-hand side of the screen here, you can listen to interpretation there. Great. And with that, I will pass it along to our presenters today.
Good morning. So my name is Anna Crawford, and I'm just going to introduce a couple other things before we get started with the discussion. Many of you have seen the Learning Resource Center, so I'm going to share my screen so that we can show you around so you can see some of the resources available to you. So all of our materials today you can find on the Learning Resource Center under the Oxygen Series course. You should have received a link to log in to the Learning Resource Center. And we just want to remind everyone the context of these discussions is that childhood pneumonia is the leading cause of death in children under 5. SARI and ARDS. Oxygen is the first therapy for patients with these infections and lung conditions. Hypoxenia increases the risk of death, but is easily detected using pulse oximetry. And pulse oximeters and oxygen therapies can decrease patient deaths by 1/3. So if I scroll down, you can see the course contents, and the case discussion series that we're running now is under the second module called the case-based discussion series. But I'm going to come back up here and just let you know that we have a 1-minute disclaimer video that I'm going to play for you now, and then I'll tell you about some of the partnerships that and resources that are involved in this. The following learning modules are intended to promote the exchange of knowledge and experiences of healthcare providers. Learning modules are in no way intended to substitute the clinical judgment and independent decision-making of qualified healthcare professionals. Viewers of this material are fully responsible for their own clinical decision-making. Creators of these materials are in no way liable for any claim, loss, or damage resulting from information used in this Learning Resource Center or during discussions. Creators and administrators of the Learning Resource Center make every attempt to provide up-to-date and accurate information. However, information changes rapidly. Creators and authors cannot claim responsibility for inaccurate information. Individual healthcare providers are responsible for adapting information to fit availability of resources and standards of care in their own institutions. Okay. The next thing I want to share with the audience is disclosures and conflicts of interest, the partnerships that have led to this series, as well as the development of the Learning Resource Center. It's important for you to know how that came about. So the Global Anesthesia and Critical Care Learning Resource Center aims to bring high-yield, evidence-based, and peer-reviewed resources to its learners, regardless of resource settings. And we pledge that we will keep education open access and free. We pledge to keep it free from advertising. We pledge to uphold ethical standards, and we pledge to approach all learners with compassion. So the partners that have brought you this series include Project ECHO, who is a collaborating sponsor, Assist International, who's also a sponsor, and Stanford University's Learning Resource Center. So we'll move on to the case-based discussion series, and I'll turn it over to my colleagues. So again, we're going to go to part 3, which is escalation of care. And one thing I wanted to point out to the learners is, as we go through this discussion, again, you can access all of these materials. For each question box that we will discuss, you can actually click on that box, and that will give you the reference or the resource that we're using to host our discussion and come up with answers and solutions to problems. The other thing I want you to note is this paper clip in the upper right-hand corner. If you click on that, there are 2 downloadables. One is the PDF of the slides for this presentation, and the other is a checklist for practice change. So with that, I will stop sharing my screen and introduce Dr. Kano and Dr. Mary Rose, who will be leading this discussion today.
Okay, thank you.
Are you ready to get started?
Yes, I'm ready to get started.
Okay. Okay.
All right, thank you. So as introduced, my name is Dr. Mohamed Kaino. A bit of correction there. I work with Kio International Hospital in Kenya. I already relocated from Kilimanjaro Christian Medical Center. So today we are going to look, as already introduced this session, I will present a case to you, but before that, I would like us to look at the objectives. If you can scroll up a little bit. Yes, thank you. So these are practice change objectives. There are 9 of them. Number 1 is to develop decision-making competence about when to admit patients to the hospital using triage protocols and hospital admission criteria. Number 2 is to define mild, moderate, severe, and critical illness from COVID-19. Number 3, develop decision-making competence about how to design isolation areas for patients with suspected COVID-19. And then following is to design and follow protocols for escalation of oxygen therapy to these patients. And then decide when the patient needs to be evaluated by a senior physician. And then decide when the patient needs to be evaluated by an ICU team. And if you have no ICU in your hospital, then you have to decide if and when a patient can be transferred to a higher level of care. And then you have to recognize how critical care can be provided outside an ICU. This is in case if you cannot, you do not have an ICU and cannot refer patient to higher care. And then understand when to refer to a higher level of care within the context of available resources. So these are the objectives, and I'll go ahead and present a case to you. If you can scroll ahead, please. Yes, keep scrolling. Yeah, thank you. So I'll present this case to you, and then you can keep posting questions if you have any, and we'll pause every now and then for a short discussion. So history of present illness. We have a 36-year-old male who presents to the emergency department with a 2-day history of fever, cough, and shortness of breath. In the emergency department, the patient was screened for COVID-19 risk factors, isolated from other patients, and is wearing a face covering. Now, you arrive to evaluate the patient and realize it is your colleague. You are wearing PPE for contact, for droplets, and airborne precautions. And the patient admits he is in short of breath, has fever and a cough, but denies loss of taste and smell. His vitals are temperature 37 degrees Celsius, blood pressure 110/74 millimeters of mercury, heart rate of 94 beats per minute, respiratory rate of 18 breaths per minute, and saturation of 92%. This is on room air. So you placed him on oxygen therapy at 5 liters per minute by nasal prongs before continuing to obtain a history and perform a physical exam. Now, past medical history, he's healthy, but has had bronchitis in the past. Surgical history, had inguinal hernia repair in 1988. That's long time ago. And there is no medications that he's currently on. Family history, mother deceased, history of hypertension and diabetes mellitus, and father deceased, history of emphysema. Has 1 younger sister who is healthy and have 2 children who are also healthy. Social history, he works as a general practitioner, physician, does not smoke, and does not use illicit drugs or alcohol. Can you scroll up again? The dialog box is coming up, that's one, yeah. So review of other systems, it's negative otherwise, other than the history of presenting illness. In physical exam, neuro, this patient is alert and oriented to people, place, time, and situation. And the pupils are equal and equally reacting to light. And he moves all extremities well, non-focal. So the airway is Malampati 2, normal range of movement, interstitial distance of more than 3 centimeters, dentition intact, and thoromental distance of more than 6 centimeters. Cardiovascular system, you have regular rate and rhythm, and there is no murmur, no rub, or gallop. Capillary refill, less than 2 centimeters, which is normal. Pulmonary exam, you have cause, basal sounds anteriorly, tachypnea to about 32 breaths per minute, and the abdomen is soft, non-tender, not distended, with bowel sounds heard normal. Extremities, you have bilateral rim edema +2, and skin is warm, dry, and intact. So the question that we pose to you is, how would you admit this patient to the hospital or manage at home? Does he have mild, moderate, or severe illness?
So again, you can type your answers in the chat box or send them home. Dr. Kano, what do you think of the smallpox? Most people want to admit him to the hospital, it seems.
Okay. Oh, sorry, I didn't check on the. So I think this patient, yes, should be admitted because the patient is desaturating on room air and has tachypnea. So this patient should be admitted. I will just review a bit of classification of COVID, severity of COVID-19. And I'll try to compare that with one from a hospital here in East Africa. So
you want to go back to that?
Okay, so I'm just going to touch base with a bit of maybe classification here.
So we can click on the question resource for you.
Yes, if you can do that, I'll go quickly and compare with, yeah.
And scroll down to asymptomatic, pre-symptomatic infection. Perfect.
Yeah, so the first class is asymptomatic or pre-symptomatic infection, where these patients test positive for SARS-CoV-2 with PCR or any other nucleic acid amplification test or antigen test, but they have no symptoms at all. So no symptoms of upper respiratory tract infection or lower tract respiratory infection. And then class 2 is when you have a mild illness, and this involves the symptoms of the upper respiratory tract infection, which include, as you can see, fever, cough, sore throat, malaise, headache, muscle pain, nausea, vomiting, diarrhea, loss of taste and smell. So mostly you could look for, cough, sore throat, and other symptoms that have been listed here. But these do not have shortness of breath, dyspnea, or abnormal chest imaging. Number 3 is moderate illness. These are individuals who show evidence of lower respiratory disease during clinical assessment or imaging, and who have saturations of more or equal to 94 on room air at sea level. And severe illness are those individuals with saturations less than 94%, and have a PF ratio less than 300 millimeters of mercury, respiratory frequency of more than 30 breaths per minute, or lung infiltrates of more than 50. And then the last one is critical illness. And now these are patients with septic shock and multiple organ dysfunctions. Now, comparing this with, if you can just leave it here, I'm just going to mention another classification of disease based on severity here from one of the hospitals in East Africa. And I'm sure most of you have, different classification of these patients, but they are very relating to each other. So the first class is asymptomatic or has upper respiratory tract infection. So has no symptoms, that is being asymptomatic, or have fever of more or equal to 37.5 degrees Celsius, cough, sore throat, headache, fatigue, and there's nothing that is seen on the chest exam, okay? So such patients are just given supportive therapies, paracetamol, vitamin C, and zinc. And they can be allowed to go home, or they can be asked to stay if they have the upper respiratory tract infection, depending on where the patient is coming from and their socioeconomic background. And then you have the second class, which is mild lower respiratory tract infection. And these patients will have all the symptoms that are in class 1, including, and on top of that, they will have difficulty in breathing, chest pain, and respiratory rate less than 25. they may have chest exam suggestive of pneumonia. So on top of that, you may add maybe an antibiotic. And then number 3, moderate lower respiratory tract infection. They will have difficulty in breathing, but the difference is they will have respiratory rate of more or equal to 25 and saturation more than 90, and chest x-ray will show pneumonia. And then number 4 is severe lower respiratory tract infection, who will have all the above symptoms, but their saturation will be lower than 90 and blood pressure will be lower than 90/60. Respiratory rate will be more or equal to 30, and chest x-ray will show pneumonia or ARDS. So you can see the two have that difference. The first one is asymptomatic or upper respiratory tract infection. Now you can compare, as I'm reading from the other side, you can just compare. The first one is asymptomatic or upper respiratory tract infection. The second one is mild lower respiratory tract infection. The third one is moderate lower respiratory tract infection. And the fourth one is severe lower respiratory tract infection. So there is no critical illness in this classification here. So maybe we can move forward from here.
Can we discuss for just 1 second, Kano? Is it okay to stop sharing screens and just ask other panelists their
Yes,
experiences? I think experiences in different settings might be helpful for the learners. So we do have a poll question too, and since the question was about whether or not to admit the patient or send the patient home, if we can get the participants to answer in the chat box this poll question. So Dr. Kano and Mary Rose, in defining the severity of COVID-19 illness, it becomes important to some degree in that the indication for some of the therapeutics are based upon severity of illness. For example, remdesivir and dexamethasone. So at what point in your setting would you consider those therapies?
Okay, so these are considered according to the conversation I've had with physicians who are handling COVID patients. These are considered on moderate to severe lower respiratory tract infection. So moderate to severe. Just not that they don't have the critical illness here.
Okay.
In Nigeria, we give remdesivir and dexamethasone to patients with severe illness.
And severe illness being defined as having an oxygen requirement, isn't it?
Definitely.
So yeah. Dr. Mull, how do you do it in Switzerland? You're muted, dear.
Sorry. We now try to give remdesivir to patients before they enter the ICU. So I would say we probably give remdesivir to patients in moderate disease. We don't follow the NIH classification. We still currently follow the initial SCCM and ESICM guidelines of mild, moderate, and severe ARDS and COVID.
I would like to add something. In Nigeria, we do not, remdesivir is not widely used. Some other antivirals are used. I just want to add that clause here. Just maybe very few centers may have access to remdesivir. So we use some other antivirals, and they're usually reserved for critical, severe illness. Thank you.
And Arthur put that if a patient needs oxygen in Uganda, then they get dexamethasone, which is essentially what we do as well. Thank you.
Yeah.
Okay, back to you, Dr. Kano. Sorry, I just want to make it interactive discussion.
Yeah, it's okay. So I think, can we go back to this slide? So I think most of the hospitals here will give they will give 2 antibiotics like azithromycin and ceftriaxone. They will give heparin, dexamethasone, tocilizumab. They will give zinc, and but they don't give antiretrovirals, even for severe illnesses. Maybe because they don't have it, or the evidence of what they have is not convincing enough.
Thank you, Dr. Kaino. Dr. Crawford, can I move on now to the?
Yes, thank you. Thank you.
Okay, so we're going to have some practice change action items. The first is we're going to develop triage protocols and admission criteria for patients with suspected SARS-CoV-2 infection. We're going to discuss that. And then also educate all providers regarding the definition of mild, moderate, severe, and critical illness with COVID-19. Sorry, I think we just discussed that. We'll be moving on to what is an airborne infection isolation room.
Yes.
And I'd like the participants to please type in what they think an airborne infection isolation room is. Your hospital does not have AIIRS, an airborne infection isolation room. What other options do you have to isolate patients and keep both providers and patients safe? We encourage the participants to please type in the answers to the questions in the chat room. The first question is, what is an airborne infection isolation room? And then secondly, your hospital does not have an airborne infection isolation room. What other options do you have to isolate patients and keep both providers and patients safe? Okay, I can see someone has typed in a negative pressure room. Okay, and someone else equipped with negative pressure ventilation system. Okay. Okay, and in Mexico, we do not have isolation rooms. Sometimes rooms are adapted. Okay, another person is saying a properly ventilated room and PPE. Okay, so yeah, that's about it. An airborne infection, an airborne infection isolation room. Okay. There's a poll here. Okay, I can see from the poll, it's tending towards many people not having the airborne infection isolation rooms. Okay, so what other options do we have to isolate our patients? What are we using right now? Because we have to treat these patients. If we don't have the airborne infection isolation room, what do we use to keep these patients safe? And has been said, airborne infection isolation rooms are, yes, rightly, negative pressure rooms where we treat patients with airborne infections that can be easily transmittable. And the negative pressure about it is that it traps air into the room. It doesn't let the air leave the room so that it doesn't spread the infection when the door is open or even when the door is shut. So it traps air into the room. And then there are air changes, etc.
So if I may, Mary Rose, a lot of the building engineering design that we have in place for airborne infection isolation rooms comes out of the literature from tuberculosis. And what happens in these rooms is usually it's only 1 to 2 patients per room, depending on the census of the hospital, but they use central ventilation systems to essentially pull air out of the room, and they use HEPA filters to filter that air. And the ventilation systems change the entire volume of air within a room a certain number of times per hour. And it's so much so that it actually creates a slightly negative pressure within that room because the air is being pulled out of the room. And the reason you want to have negative pressure inside the patient's room is because when you open the doors, you don't want the room air from the patient's room to go out into the hospital environment. So the point of having negative pressure is to pull air into the patient's room and away from the environment where other providers and other patients may be. So it's a common thing in very high resourced hospitals, but as we see in the poll, we have very few places that actually have this resource. So we have to come up with other ways to isolate our patients and to utilize natural ventilation and fans, et cetera, in order to create a similar scenario where we can decrease risk to the environment.
Thank you very much, Anna. Okay, so I'm pretty sure everybody is treating COVID in one capacity or the other in their countries. So I'm seeing some answers. Ensure having a well-ventilated room, keeping patient space distance 1 meter. Exactly. So there are some other ways we can care for our patients safely, keep the patient safe and the providers. And one of it is to have very well ventilated rooms where air comes in and air comes out, so that the airborne particles do not remain in the room for too long, so they are swept away by air or wind. And then another way is to use fans. We can also use fans, and the strategic positioning of those fans so that they blow air away from the non-infectious side of the room towards the infectious side of the room, protecting the non-infectious side. And then the fans can be standing, wall-mounted, etc. And also spacing the patients, keeping them a certain distance apart. Those are ways. Anna, can we click on this? Do you want to click on this?
Actually, we have a poll question as well we can launch now.
Okay.
Yeah, but if you want to, yes.
Okay.
So which of the following methods does your facility use to decrease the spread of airborne infectious agents? Select all that apply, so you can select more than one. Did you want to go through the tuberculosis manual though? Yes.
Okay. I just wanted to show the different ways, but It's okay. This is fine. Another thing as shown in this poll is some hospitals have the HEPA filtration devices that they place in the room, and they help to filter the air in the room. I don't know. Okay, from the poll is showing that it's not very common with many of us here, but I know 1 or 2 hospitals have it in Nigeria, but it's still not very widespread in Nigeria.
So the resource that we're sharing that says tuberculosis infection control, if you go to page 26 in this PDF, which actually may be, it discusses natural ventilation and fans. Is this what you wanted, Mary Rose? Yeah?
Yeah.
Mm-hmm. So anybody who needs more information on designing patient space for isolation and using ventilation, this is a really great resource and reference for designing airborne infection isolation areas.
Thank you, Anna.
I think sorry, I just wanted to make sure that everybody knows what HEPA filters are. HEPA filters are high efficiency particulate air filters, and they are meant to filter out 99.95 or 97% of particles that are equal to 0.3 micrometers or larger, so that everybody knows what we are talking about.
Okay.
Thank you, Dr. Mo.
So continuing with our presentation, if you can scroll up, I think we are done with the practice change items. Yeah, so in addition for our patient, in addition to ordering nasopharyngeal swab for SARS-CoV-2, what additional diagnostic investigations will you order for this particular patient? If this patient was in your hospital, you can type your answers on the chat box. So we are moving on with our case here, and the question is, in addition to ordering a nasopharyngeal swab for the patient that we are discussing here, what additional diagnostic investigations will you order if this patient was in your hospital? I see people answering here: chest X-ray, arterial blood gases. Any other investigations? Anybody else? If you have a COVID patient in your hospital, what investigations are you going to order? Okay, so for this patient, we have chest X-ray here. If we can scroll up. And it does look kind of normal. So the patient is admitted to the hospital and transferred to an isolation bed on the hospital ward. He remains on 5 liters per minute by nasal cannula. When he arrives to the ward, the nurses obtains a new set of vitals, just like You can see below here, heart rate of 99 beats per minute, blood pressure 103/60 millimeters of mercury, respiratory rate of 28 breaths per minute, and saturation of 89. And the temperature is 38.5. So moving on to, you can keep texting on this chat box if you have an idea of other investigations you would like to test. But also we're moving on to the next question for the interest of time. So there's a question here. When should oxygen therapy be escalated? Okay, people keep answering. On investigations, they say you can order other labs or imaging. What other labs? Perhaps venous blood gas if ABG is not available. Okay. Full blood count, D-dimer, liver function test, ferritin. These are kind of standard investigations for COVID patients, but most of our hospitals here cannot do these investigations.
I think, if I may, Kano, point that out, that many places lack the ability to check a lot of the labs and do a lot of the investigations that are recommended in protocols from higher resource settings. And one thing I would just like to point out is that a lot of those labs are really for academic purposes. They show the level of inflammation that a patient is experiencing, but they don't necessarily change your management of the patient. So I would argue that not all of those labs and investigations are necessary when your resources are constrained. I think a full blood count and a complete metabolic panel are very important. I think a chest X-ray is imperative. And then vigilant monitoring with SpO2 is also very important. But I would like to hear from the panelists, what other labs do they think are mandatory to optimize treatment of patients when you don't have access to things like D-dimers or ferritin or CRP or ESR or any of these other labs. I think, Jean-Claude, you mentioned D-dimer, liver function tests, and ferritin. Are all of those labs available in your hospital? Does anyone else have an opinion about what labs are most important?
Okay.
Yes,
Can
Shelley,
you guys hear? I was going to say something. Honestly, this is not what labs are available, but good patient observation is extremely important. You could look at a patient's color for cyanosis, their respiratory rate and depth, and just you can really get a good, solid idea of their level of respiratory distress by observing them. Mm-hmm. Their color, their skin color, and things like that.
Yeah, I completely agree. So, I think with COVID-19 patients in particular, though, we have to be careful because virus can affect almost every organ of the body. So we have high rates of cardiomyopathy, high rates of renal failure. We also have liver dysfunction in some patients. So it is important to recognize organ dysfunction in these patients, whether that's using clinical exams or whether that's using investigations.
I agree. I was kind of thinking along the lines of escalating care as far as oxygen usage, but you're absolutely right. And sometimes patients come in and they look great and they're not doing well at all with COVID. So keep that in mind too. Yeah.
Yeah, I think another thing is a blood culture, because these patients can easily turn into sepsis, especially in environments like ours where you can easily get superimposed bacterial infections. So I think a blood culture, especially if the patient is very febrile and all that, may come in handy. And then also the electrolytes, like you said, Anna, we need to watch, look out for damage in other organ systems. So electrolytes and urea, creatinine to check the kidneys, basic tests like that are also very important.
Along the lines of cultures, I would also argue that if you can do a sputum culture, that might be helpful, because a lot of patients with viral pneumonias end up with superimposed bacterial pneumonias. So that's another thing that will help you decide which antibiotics are most appropriate. Wonderful.
Yeah, but for those hospitals where they do not have these investigations and they cannot refer a patient to a higher care level, I think we need to give an alternative on what they can do if they find a patient with COVID and cannot refer them to an advanced center in their referral systems. I think in sub-Saharan Africa, most of the referral hospitals have most of these investigations. So these investigations will be done in those hospitals, including CT scans and the rest that we've listed here. But just in case they cannot refer this, or the patient is too fragile to be referred, or there's no bed where they want to take the patient to, and they have to manage the patient where they are. So I think what Sheldon Porter said is very important, that you need to monitor the patient on using the vital signs, so kind of vital sign directed therapy, and specifically saturations, and give oxygen therapy. Which takes us to the next point. If Anna Crawford, you can, who is displaying the okay.
We switched to Alana so that I can help you manage the chat box.
Okay. Thank you.
Yeah, Alana, yeah.
All right, so we're going to our next question here. When should oxygen therapy be escalated? And again, I would like everyone to, we can go through this, but everyone to try to answer in the chat boxes. So everyone can put their answers in the chat box as to when do they think oxygen therapy should be escalated. This is additional resource. If you click on the blue box, you will get to this. It will take you to this resource, and you can revise to read more about oxygen therapy and escalation of oxygen therapy.
Don't be shy. You can type your answers in the chat box. When do you escalate oxygen? What signs or symptoms prompt you to escalate oxygen therapy for your patients?
So there are questions here. All right, for areas who have saturation monitors, a protocol can be followed. However, in areas without saturation monitor, what shall facilities do?
Ideally, pulse oximeters are available everywhere oxygen therapy is available. But there might be instances where people have oxygen but no pulse oximetry. So I would argue they would need to follow clinical exam and signs and symptoms of respiratory distress and hypoxemia. We have some shy participants today.
Yeah, don't feel shy. You can post your questions or answers here in the chat box.
Oh, we actually have some folks that are raising their hands, which is very polite. Thank you. So we will maybe ask TV to unmute.
I think the Echo India team just has to, oh, there we go.
Yep, got it, yeah. Tejas, did you have some comments about when to escalate oxygen therapy?
I would like to inform you that our chat box has been disabled, so we could have texted it.
I understand. Okay, thank you for letting us know. We'll try to fix that. And how about Nam? Is it the same problem? Nam Goji?
Yes, it's the same problem. Thank you.
Okay. Okay. Thank you for letting us know. Apologies.
Yeah.
So maybe as panelists, we can discuss the signs and symptoms of hypoxemia and respiratory distress that would prompt us to escalate oxygen therapy.
Okay, so it looks like the chat box has been enabled again. Maybe people can post a few answers or questions. If saturation falls, dyspnea, increase in respiratory frequency. That's correct.
Perfect. I thought our panelists, or I thought our participants were shy, but maybe their chat boxes weren't working.
Yeah, they were kind of.
Sorry.
Please feel free to post your answers and questions here as the panelists continue to discuss about
COPD, someone says.
I'd like to make a comment about COPD, if I may.
I would too, yeah.
So I know that it's a concern about high levels of oxygen in people with COPD, but in the environment of COVID, that kind of goes out the window a little bit. So I want to say it right. Don't worry so much about the whole COPD and too much oxygen and things like that. You want to make sure that your patients have enough oxygen and you're not leaving them hypoxic, if that makes sense. I know some facilities that I've worked in, you want to keep it lower, but don't worry about it being such a hard, fast rule, I want to say. Does that make sense? What do you think about that, Anna?
Well, I'm going to just take it back a step and explain a little bit about COPD and oxygen for those who don't understand why that's perhaps a bit of a challenging clinical situation. So patients with chronic obstructive pulmonary disease, in its main form is emphysema, there's some concern about delivering high levels of oxygen in that it might make that patient somewhat worse. So in general, we target lower SpO2 or pulse oximetry readings in COPD patients. And so typically we would target 88% or greater. So despite targeting levels of 92 or 94 in some other patients, for our emphysema patients, our target is actually much lower. The current or the most common thought is that COPD patients over time develop a hypoxic drive to breathe, meaning that they actually need these lower levels of oxygen in order to have a respiratory drive. That's actually not true. That's not the true reason why patients with COPD sometimes will do worse with high levels of oxygen. It's a result of a physiologic phenomenon called hypoxic vasoconstriction. And hypoxic vasoconstriction occurs when areas of the lung are unable to participate in gas exchange. And when those lung areas, such as in emphysema, cannot participate in gas exchange, the blood vessels around that area will constrict, and they will divert blood to areas of the lung that can participate in gas exchange. So what happens when you deliver excess oxygen in these patients is those blood vessels that constricted will actually begin to dilate. And so what you are actually doing is you're causing a shunt, because you would have perfused but not ventilated areas of lung. So in general, the target, I would say, the simple takeaway with COPD patients is that an SpO2 equal or greater to 88% is probably adequate for that patient population. Sorry for the deep dive into physiology, pathophysiology, but I think it's important to understand that emphysema patients do need oxygen, but they don't need the same high goals as other patients would.
Thank you. Well said. Thank you. I just didn't want people to get so caught up in, oh, is it a COPD patient or not? How, you know what I mean? You know what I mean? So that people aren't necessarily getting the oxygen they need.
Exactly.
Don't be afraid. That's it. Basically, take away, don't be afraid to oxygenate your patient.
And Shelley, I want to introduce Shelley specifically. She's a respiratory therapist at Stanford University. And the role of a respiratory therapist is very important when you have them. They help physicians and nurses manage ventilators, oxygen therapy devices, non-invasive ventilation, high flow oxygen therapies, et cetera. That role of the respiratory therapist is not common in some other situations. So for example, in Rwanda, we don't have respiratory therapists. So it's a very specialized role that we're grateful to have in our setting. So thank you, Shelley. So Kainel, back to you and Mary Rose.
The normal goals for SpO2 will be like 90 to 92 for patients who are not pregnant and do not have COPDs, and so we are targeting at 90 to 92 around those areas. For pregnant, should be above 95% saturation in COPDs, as Anna has so well described, should be above 88, but not bad if it doesn't go above 92. So I would like to ask another question as a sub question of this part, that how would you consult either a senior physician or ICU with regard to oxygen therapy and oxygenation in these patients? If we can get answers to these, please, on the chat box, or if you can raise your hand and say answers if the chat box is inactivated on your part. The question is, at what level of oxygen therapy do we consult a senior physician to come and review the patient? Or at what level do we consult ICU staff to come and review this patient? If we can have those answers coming, please. So your target is 90 to 92 for normal people, normal patients, COVID patients who do not have any other comorbidities. And for pregnant women who have COVID, you want to target above 95%. And for COPD, above 88. But don't struggle too much to raise it if it is already between 88 and 92. But now, if you have problems achieving these goals, when are you going to call the consultant physician to come and review the patient? Or when are you going to decide that I think this patient is for ICU and call ICU people to come and review the patient? That's the question. You can keep the answers coming.
So Lucy says an increasing oxygen need. Maria Cristina says 90s, decreasing, not responding to therapy. Sabine says, if we have the facility, we will consult a senior from the beginning when the decision to give oxygen to a patient is made. When normal COVID patients don't maintain 90 to 92 for 24 hours or get worse at any time, or increasing oxygen need from Usman Mohammed. All very good answers.
Yeah. So I will allow Anna, maybe we can keep discussing about this with the panelists as we keep on receiving answers from different participants. When the patient is not responding well to oxygen therapy, that's non-GOGE. Susanna says, any saturations less than 90, she will consult senior physicians before oxygen administration and decrease in saturations. Less than 90 for normal patients and less than 94 for pregnant women, which is correct.
I think maybe we could have a little bit of discussion about why the SpO2 goal is different in different patient types. And why many times we hear different numbers. We hear 92, we hear 94, we hear 90. Where do these numbers come from? How come we can't have just one number? And so I would like to just maybe engage the panelists in a discussion about where these numbers come from and what does the oxygen saturation number even mean inside the body. Vanessa, do you have any things you want to share about that pathophysiology of oxygenation and hypoxemia versus hypoxia, or why it may be a higher SpO2 for a pregnant patient or a septic patient? I don't want to put you on the spot, but I think you might have some good answers.
Sure. So we are measuring the oxygenation with usually with a pulse oximeter, and so we are looking at the ratio of oxygenated hemoglobin to non-oxygenated hemoglobin, we basically use the hemoglobin to transport oxygen to the end organs. And while everybody loves to have one number like 100%, for example, we have to keep in mind that hyperoxemia, so too much oxygen, is also detrimental. So too much oxygen in your lungs, we all are breathing in 21%, but if you have too much oxygen, it can create damage to the alveoli, and it can cause inflammation of the alveoli, leading to fibrosis eventually. So we are always wanting to be on the safe side, giving the patient enough oxygen. to support the organs, but not give the patient too much oxygens to cause harm. And why do different patients have different targets? It basically depends on their own physiology. So the COPD patients, as you beautifully explained, have a protective shunt mechanism, basically, in their lungs, where they shunt off the diseased lung to be only using the healthy lung to oxygenate. Whereas a pregnant patient, for example, is basically two patients in one. And so you want to have a higher margin of safety in these patients. At times, it's important to have a bit of a higher safety margin, especially as you're in sepsis, for example, where you're in a hypermetabolic state. So you use up your oxygen supply faster than in a resting state, if that makes sense.
I think it makes great sense. And I would also add, Vanessa, not only is it your oxygen demand, so if you're pregnant or you're in septic shock, or you have some other inflammatory problem systemically, you're going to have an increase in your oxygen demand, which means all your cells and all your tissues need more oxygen. So you need to set your SpO2 a little bit higher. So oxygen demand is one variable in the equation. The other thing to consider is also oxygen delivery. So if you're in a shock state, if you have cardiac arrest, if you have cardiogenic failure of some sort, or any sort of shock state, you're also, even if you have oxygen in your blood, may not be able to effectively deliver it to all of the cells and tissues. So in that situation as well, you want to target a higher SpO2. So in general, for normal patients, we would say 90%. For pregnant patients, greater than 92%. For septic shock or other types of shock states, we would want to target higher than 94. So again, you're going to get different numbers, but the reason is measuring the amount of oxygen in the blood doesn't necessarily tell you how much oxygen is being delivered to tissues. So it's one way to measure, but it's not measuring at the cells and tissues themselves. So.
Okay. If you can show us the slides, please. So I was trying to look for the answers as to when people would call a senior physician or call ICU for admission to ICU of this patient. And people say it depends on the PF ratio values, oxygen tension. Besides oxygen saturation, what other parameters can you consider to evaluate more precisely? Decreasing level of consciousness, partial pressure of oxygen less than 60 millimeters of mercury, and pH of less than 7.2. When on rebreathing mask, 15 liters per minute, and no improvement of saturation less than 90. So generally, I think regarding oxygen therapy, when you call a physician, it's recommended that maybe when you are on the FiO2 of more than 40, that is equivalent to flow on the prongs at 6 liters per minute, and the saturation is 90 or below, then you may want to call a senior review. You may want to call for a senior review. And if your FiO2 is more than 50%, that is equivalent to 8 liters per minute on mask. And the patient fails to maintain a saturation of 90 and above, then you may want to consider ICU alternatives. If you have it at the hospital, then you call them. If you do not have them, you may want to refer a patient to a higher center who have ICU. And you can see a document being shared here, please. You can just click on the blue box here, and it will take you to the resource where you can review correct information or recommendations on what you can implement in your hospital. So from here, maybe I will ask Dr. Mary Rose to continue with the next question.
Mary Rose is having some microphone difficulty, so I was going to see if Project Echo can make sure she is unmuted. She had to sign in an alternative device, so needs to be given.
Okay, so then I will continue. So Anna, do you allow me to continue to the next question?
Yeah, you can. Yes, of course. Thank you.
Okay, all right. What is the role of awake prone positioning? So this is a question posed to you, and you can give answers on the chat box down here, or you can ask questions.
And Mary Rose
we have a fantastic panelist here. Mary Rose, we are discussing about the roles of awake prone positioning of patients.
Yeah, thank you very much.
In oxygenation.
Yeah, I'm back. Yes, thank you.
Yeah, so I just asked people to post their questions or answers to this question on the chat box.
Yes, please. Okay,
so let's see. Yeah, okay, continue, Mary Rose.
Okay, so since the COVID era, before COVID, there was prone, but there was proning in ICU, proning of patients. But since COVID, we've been hearing about proning, and how proning really helped to prevent putting patients on mechanical ventilator, and how it really improved outcome in a lot of patients. So what is the role of awake prone positioning? We're getting some answers, and I'm seeing here increases the recruitment of non-ventilated or atelectic alveolar areas, allows dorsal areas of lungs to get better ventilation, decrease pressure on the lungs, so improvement of compliance, recruiting alveoli, better perfusation of low lung segments, improved oxygenation, better drainage of fluid in the lungs. All these are fantastic replies. Yeah. So I can see that we agree that there's a role for awake prone positioning. The thing is, it's usually advised to prone when the patient can, can cooperate. Although I know proning is also done for some patients who cannot really cooperate on their own, maybe who may have some altered sensorium. Yeah, and you may need to use pillows to assist you in proning, putting the patient in the proper positioning. And then you do not leave the patient to remain prone 24 hours. You prone and then you turn around the patient around intermittently. Anna, I'm seeing a lot of questions about prone here, prone positioning. So I think the participants would really like us to discuss this. There's so many questions. What are contraindications to proning? And then it has limited roles in obese trauma patients. Then there's another one, when to prone. So I think it's something that we should discuss. What do you think?
Yes, I agree. I see a lot of great answers, and you know, it does improve oxygenation. It helps with recruitment. It improves the ventilation and perfusion matching as well. And I would just say that prone positioning has been around even before COVID. So we've known for quite a long time, actually, that prone positioning improves oxygenation in patients. And then I'll also say, just also remind all of the participants and panelists that on November 23rd, we're having a really great, huge panel of experts, and we're going to do a frequently asked questions roundtable discussion. And this comes up quite a bit. So we'll get into further discussion about prone positioning. But prone positioning can be used in both the awake patient, ideally, you know, that they're cooperative and they can self-prone. And then it can also be used in the intubated patient. So there are protocols that have been developed for both of these. And so we have a resource that we actually didn't share in this discussion, but there's a really lovely diagram and decision-making tool that we have shared in our frequently asked questions session. So I'm going to just share my screen briefly, if that's okay, to show you this tool that is available on the Learning Resource Center. So this resource was developed by the Intensive Care Society. And you can follow a basic diagram tool for conscious proning process. And so a lot of the questions are about contraindications. So respiratory distress or respiratory failure is a contraindication in an awake conscious patient because that patient probably needs to be intubated. So immediate need for intubation. Hemodynamic instability or requirement of vasopressors is a contraindication. A patient who is agitated or has altered mental status is probably not going to do very well in the prone position. So that's a contraindication. And then an unstable C-spine, thoracic injury, back injury, et cetera, or recent abdominal surgery or abdominal wounds are also contraindications. Some relative contraindications include facial injury, neurologic issues such as frequent seizures, morbid obesity, pregnancy, and pressure ulcers or sores. So we'll get into the rest of this protocol on this document next at our next session on November 23rd, when we have a very high yield, large panel of experts, and we'll go through all of the frequently asked questions from both the last oxygen series as well as this oxygen series. But hopefully that at least answers the contraindications to awake proning.
I just wanted to add something to the proning. So the proning, the last trial, big trial that we had was the Pro-Sever trial from 2013. And in this trial, patients were prone that had a PF ratio on less than 150. And if these patients were prone for 16 hours at a time or more before turning them back and then reproning them, they had a benefit in 28-day mortality. And so, as Anna said, we have known that proning has been helpful in the past, but with COVID now, we actually started to prone awake patients, which we have not done before, really. I think the awake proning is something that has started during the pandemic. And has proven to be very helpful in COVID patients.
Can I add something about proning? I'm sorry, Dr. Mole, are you finished? Okay. I have a question for Dr. Mole, and that is, so you're proning for about 16 hours, then how long is the rest on the patient's back before you reprone?
Yeah, so, I think it depends on the hospital protocol. I think in the Pro-Sever trial, it was at least 4 hours in the hospital here at the University of Zurich. We at times only do 2 hours and then reprone them because the patients, and this is in intubated patients, because some of these really severely ill, critically ill patients, they tolerate being prone way better than being in the supine position. So we just give them rest for 2 hours, and then the proning team comes back in to prone them. And that actually, there is probably another, this needs to be known too, that proning is not very easy in patients. And so, especially when they're intubated or have a lot of lines in them. And so it's better to have a team that knows how to prone, or you do a timeout before you prone, so that everybody has his or her position and knows what to do to safely prone the patient.
Thank you. One more thing. I know we want to move forward, but I would encourage that everyone looks into proning, because it can really decrease the escalation of care a lot of times, as escalation of oxygen therapy needed. So in areas that don't have the ability to quickly send anyone out, I would encourage that people really look into proning as a pretty important piece in treating COVID patients. And also, proning can be done on a nasal cannula, high flow. I'm not too sure about a BiPAP, but I don't know about the safety of that in a BiPAP, but that's something to keep in mind. Obviously, you don't want to put the patient on there. You want to make sure that they can breathe and their face is either to the right or the left with one of those devices on, but you can still prone with oxygen devices on the patient's face.
And again, we'll talk a lot more about this at the next session on November 23rd when we get into frequently asked questions. That session will be led by some of our colleagues. So one is on this call, so Dr. Freddy from Colombia, and another colleague from India. So we'll have an even more broad perspective of these interventions. But we do need to move forward. We have only about 5 or 10 minutes left, so we'll turn it back to Dr. Kano.
Okay, can we go to the slides, please? To the Learning Resource Center. Great. So you do another physical exam. Are we on the right spot here?
I think we skipped ICU team be called to review the patient's case. We don't have much time. Did we skip that? I know.
I think I covered that we.
Okay.
That's a yeah.
Thank you.
So now you do a physical exam, and I think we go to the next question here. Is this patient in respiratory failure, and how is respiratory failure defined? So if you can scroll a little bit up. Physical exam, neuro, the only thing to bear in mind here that is on the pulmonary examination, you have cause vasosounds anteriorly, tachypnea to 32 breaths per minute. And we can go straight to the question. If this patient is in respiratory failure, and how is respiratory failure defined? So if you can click on that to bring the resource, and I would ask everybody to try to put their answers in the chat box so that we can discuss them. And if you have any questions, please keep sending them so that we can consider them for answers. So Lucy says respiratory failure is unable to oxygenate. If we can maybe quickly call in the panelists so that Dr. Anna, apart from symptoms, we need arterial gases, partial pressure of oxygen less than 60 and carbon dioxide higher than 50.
I think this slide needs to go up a bit. So we see the actual definition of acute respiratory failure and then the classification. Thank you very much. Yeah.
So this is a resource that everyone can go to later on and look at these things. The classification, type 1, hypoxemic, partial pressure of oxygen less than 50 on room air. Type 2 is hypercapnic or ventilatory. So you look at the partial pressure of carbon dioxide more than 50 millimeters of mercury. If not, a chronic carbon dioxide retainer. And then type 3 is perioperative, and type 4 is if you have a patient with cardiovascular instability.
Yeah, so I would define acute respiratory failure simply as inadequate gas exchange. With COVID-19 and with other pneumonia, SARI, ARDS, we're mostly talking about acute hypoxic respiratory failure, but you can have other types of respiratory failure as well, such as hypercarbic. I'll admit we rarely talk about type 3 and type 4. We mostly do type 1 and type 2 when we describe patients clinically in the intensive care unit. But an inability to adequately exchange oxygen and carbon dioxide is really respiratory therapy, or respiratory failure rather.
Thank you, Anna. So it can be a problem of oxygenation, as can be a problem of ventilation, or it can be both, depending on the situation. The last question is list the clinical signs and symptoms of respiratory failure in adult patients. We can quickly take that. I think that should be the last.
Okay, maybe I should just respond to Abdullah here, who says it's simply defined as an inability of the body to get adequate and proper blood and oxygen circulation. So yeah, it could be inadequate oxygen or inadequate oxygenation or inadequate carbon dioxide. Don't forget the carbon dioxide clearance. So if you have hypercarbia, that as well is type 2 respiratory failure. And you can later on take a look at the postoperative and hemodynamic instability respiratory failures. So the last question you say, it's list the clinical signs and symptoms of respiratory failures in adults.
Yeah.
So again, if you're monitoring these patients clinically and you don't have arterial blood gases, ability to do arterial blood gases to determine partial pressures of carbon dioxide and partial pressure of oxygen in blood, you may want to rely on clinical signs and symptoms to determine whether your patient has respiratory failure or not. So please, can you just put your answers and the questions if you have any? And Anna, if you can click on the blue box so that we get the and scroll to the relevant area so that we get the answers simultaneously. And Sabine is saying here, patient becoming restless, panic, skin color blue, position. Lucy says decreasing respiratory rate in the worsening patient. Okay, Sheldon says increased respiratory rate, heart rate, shortness of breath. Listen to the patient breath sounds. Okay, Anna, if you can.
Can we play this video and just have people type their descriptions of what they see in the video? This is an adult patient with respiratory distress. So type what you see in this video. So I like when the video shows his neck because you can see accessory muscle use in his neck. He's activating his sternocleidomastoid and platysmus muscles in the neck, which is not usual with normal breathing. I think we have some really great descriptions in the chat box.
Yeah, yeah. Use of accessory muscles, or turn the sounds to, you didn't turn the sound on the video anyway. So dyspnea, tachypnea, cyanosis, sweating, darkening color of blood, intercostal, subcostal usage of muscles, intercostal recession. Great answers here.
Agreed.
Yeah.
So this patient will have other signs of severe illness. They may be having their sympathetic nervous system activated. They'll be sweating. They may have tachycardia as well as tachypnea, nasal flaring, and yes, irritable anxiety, restless, dyspnea. Great answers.
And mi español es malo, lo siento, but Martha Jimenez says that difficulty breathing, working really hard to breathe, cyanosis, dyspnea, and just poor general appearance. I think that's right.
Oh, was that you, Anna, speaking?
Yeah, I was trying to speak Spanish, even though I don't do it very well.
Okay, can I add to that? In the resource, you also see that taking the upright posture in some patients is also a sign when they prefer to sit upright, and then altered mental status. All those are also signs of respiratory failure.
Wonderful. Is that your conclusion, or do you want to review the topics?
What is that?
I said, is that your conclusion, or would you like to review the topics?
Yeah, I can review the topics now. I was just trying to type something. I send it to.
It's hard to manage the screen and the chat box. I understand.
Yeah. Anyway, so the practice change action items. Recognized senior doctor should be consulted when patients require FiO2 of 40% or flows of 6 liters per minute on face mask, and to maintain their saturations above 90%. And then utilize voluntary prone positioning in awake patients with hypoxemia who have escalating needs for supplemental oxygen. Recognize a higher level of care such as ICU is needed when patients require 50% of FiO2 or an equivalent of 8 liters per minute oxygen therapy on face mask to maintain their saturations above 90%. And then list the signs and symptoms of respiratory failure in adult. We've already done that, and recognize respiratory failure or call for help. That is important as well. So key topics review, hospital admission criteria, that we need to know that. COVID-19, mild, moderate, or severe disease, we need to be able to classify that, or however you do it in your hospital. You can try to compare that to the classification that is done in this resource. Airway infection isolation rooms and patient isolation strategies. If you don't have negative pressure isolation rooms, you may need to use natural or artificial ventilation or combined in a safe way. Make sure the air is flowing towards, not towards healthy people or healthy clean equipment, but should be going away from the sick patients and not to healthy patients, or towards the wards that have healthy patients without COVID. Escalation of oxygen therapy. So you just need to know that different classes of patients will have will need different target saturations. Normal patients, patients with COVID but no comorbidities may need saturations of about 90 to 92. That will be your target saturation. Pregnant will need more than 95%, and COPD, as we've heard, it will be about 88 to 92. And then know when to call senior physician and to refer patient to ICU, as we've seen above. Okay, that's escalation of care. Critical care outside of an ICU, this is possible. So if you cannot refer patient to, if you don't have an ICU and you cannot refer patient to an ICU, a facility that has ICU, you can still manage a patient where you are. And in our setting, this is possible through consultations as well. You can call seniors in those referral hospitals and ask for advice on how to care for that patient where you are. Basic readings of chest X-ray, this knowledge is important because you need to order the chest X-ray and actually read what is on it. Awake prone positioning helps patient with difficulty oxygenation, and identifying respiratory failure in patients using signs and symptoms rather than laboratory investigations is also paramount. So if Anne, you can add anything on this, or
No.
Mary Rose, or anybody on the panel?
Thank you, Dr. Pino and Dr. Mary Rose. I think you did an excellent job covering all of the materials. So thank you so much.
Thank you, Anna. Thank you to all the panelists. Thank you.
So before the learners and participants leave, if you have just a minute, I realize we're over time and I apologize. I do want to share my screen for one moment. There's a lot of questions in the chat box about how to get the videos of these sessions, how to get the slides of the presentations, and how to get some of the other materials. So I want to review briefly how you can access the materials. And I'll put the link to the Learning Resource Center in the chat box. So you can click on that link and it will take you to the Learning Resource Center. So let me quickly show you the Learning Resource Center and how to get the slides, how to get the videos, etc. So can you see my screen? Can I get a thumbs up if yes? Yes, okay, good, thank you. So this is the Learning Resource Center. When you come to it, you can see that we're in the Oxygen series course. We have other courses on the Learning Resource Center, but this is the one that you would go to for this series. So you need to sign in. So once you go to the Oxygen series course, you can again go down to the case-based discussion series. This is the series that we're running currently. And you can see that the videos from part 1 and part 2 have already been loaded onto the Learning Resource Center. So you can grab the video for part 1, which covered triage, and you can grab the video for part 2, which discussed hypoxemia and pulse oximetry. As soon as we have the video processed for this session, we will again upload it to the Learning Resource Center. These videos can also be found on the Assist International website. And again, I want to just remind you that part 4 is a frequently asked question discussion roundtable that will be on November 23rd. And part 5, we're actually going to talk about how to deliver critical care, even if it's outside of an intensive care unit. So how to identify critical care outside of the ICU and talk about rapid response teams. So again, if you go into part 3, which is what we discussed today, I want to remind you that there is a paper clip in the upper right-hand corner. If you click on that, you have 2 things that you can download from the Learning Resource Center. One is the slides from this presentation, and the other is a checklist. If you notice throughout the presentation, we have these check boxes that have action items for you, the learner, to improve your practice. And so you have throughout each one of these sections a checkbox, and these we have compiled into a checklist that you can actually download, and it should help you teach others and also improve your own practice. So you can download this checklist and check through each item after you have completed it. So just wanted you to realize the resources that are available to you at any time. You do have to create an account on the Learning Resource Center, but after you create it once, you can just sign in. It's free, it's open access. There's the link in the chat box. You can share this with anyone who's interested. And with that, I want to again thank our amazing panelists. Thank you for all your contributions, and I'll turn it back over to Assist International. So thank you to all of the wonderful participation.
Hi everyone, this is Alana from Assist International. I just have a few notes to wrap up. Thank you to all of our participants for joining us today from around the world. Thank you to all of our panelists for sharing your time and your expertise. I'd also like to thank our funders who've made this webinar series possible. That is Project ECHO and the GE Foundation. And then, as Anna mentioned, if you would like to access the resources for this session, you can do so on the Learning Resource Center. A link will be emailed to you after the session. And as well, we saw a couple questions in the chat about certificates. To obtain a certificate of attendance, all you need to do is fill out a short survey, which will also be shared in the follow-up email. So thank you everyone for calling in today. If you have any questions for us, you can reach us at echo@assistinternational.org. I've also shared registration links for sessions 4 and 5 in the chat box if you'd like to register early. And so yes, thank you for joining, and see you all soon.
One last comment, apologies for jumping in again.
Yes.
I just want to tell all the learners that that was a real case, and that case was submitted by a colleague of ours from a low-income country. So if you have a case that you think is relevant for all the learners and you want to submit that case, you can email us, email Alana or myself, and we'd be happy to consider that case for future discussions. So thank you.